A type B injury is one where there is a failure of the posterior ligamentous complex and you need to restore the posterior tension band and therefore you do a posterior stabilization. The burst element indicates that there is a failure of the anterior vertebral body and there has to be some reconstruction of this anterior column in order to restore the load-bearing mechanics. Traditionally, these patients have been treated by short segment posterior stabilization, but in a distraction mode as recommended by the AOs. When you distract such a fracture, what happens is that the vertebral body here opens up, and like in a trabecular bone over there which was compacted opens up, resulting in a void in the center. This void nature hates and therefore eventually this void collapses and there is a recurrence of kyphosis, pain, maybe even neurologic deficit and often a failure of implant. Early failure of short segment pedicle screw instrumentation has been well reported and the cause of it is untreated anterior instability. Many different options have been described including transpedicular bone grafting, insertion of pedicle screws at the level of the fracture, kyphoplasty with calcium phosphate cement, and of course reconstruction of the anterior column from the back. Our goal was to evaluate that if instead of distracting the fracture, we compressed it on table, we brought two end plates closer to each other and the trabecular compacted bone was compacted further, then we would minimize progressive collapse, we would reduce the risk of implant failure by giving on-table stability to these patients. So we wanted to study our technique. 27 patients with unstable thoracolumbar burst fractures. As a thoracolumbar, most of them are at the T2, L1, L2 segments. 14 of them had no neurologic deficit. The preoperative local kyphosis was 17.3 degrees and the reduction in the vertebral body height was 40%. In all patients, we did a posterior short segment fixation. Index screws were used, which is screws into the fractured vertebra in all 23 patients. Average compression applied was 4.5 millimeters. We used the AO system has a C-shaped clamp which you can put next onto the rod, and when you are compressing you can measure the amount of compression you are actually doing. Anterior reconstruction other than this was not performed in any of the patients, and transpedicular decompression was performed in all patients who had a neurologic deficit. Our follow-up duration was minimum 1 year. Intraoperative kyphosis correction was an average of 13.2 degrees. But interestingly, if you see over here, the loss of correction was minimal. There was no implant failure. Residual kyphosis of greater than 10 degrees was not found and patients had excellent pain relief. Pre-op and post-op CT scans were performed in 10 patients who did not actually undergo a decompression. They were fixed in situ with stabilization. And we found that with the compression, there was a slight increase in the canal compromise, but that did not result in any neurologic deficit. So to conclude, high failure rate of short posterior stabilization is well known because of untreated, inadequately treated anterior stability. We propose that instead of distracting these fractures, compress across the fracture site to give on-table stability and reduce the risk of implant failure. Thank you.